Hello, everyone in the world. Welcome to this webinar, which will be very interesting. It is the second episode of the webinar from the European Society of Radiology on COVID pandemic in cancer care. So we all know and have seen that this COVID crisis has led to some suspension of care for all patients without corona and in specific for patients with cancer. And in many countries, there was even a suspension or a break in the screening programs. And what it had impact on screening, you learned last week in the interesting first episode of this webinar. This second episode will be especially dedicated to the impact of cancer care and the suspension of it on patients with cancer and workflows in hospitals. We have invited two excellent speakers, one from the clinical point of view and one from the radiological point of view. After their lectures of each 15 minutes, we will go into a discussion with them where you as a listener and participants can ask and fire them questions through the chat functions. So before they will introduce themselves, I will introduce myself. I am Regina Beets-Tan. I'm radiologist, head of the Department of Radiology, working in the Netherlands Cancer Institute in Amsterdam. The first part of the lecture, which will be the point of view from the clinician, will be given by Dr. Gabe Sonke, who is a medical oncologist in my institute, the Netherlands Cancer Institute. He will address the workflow changes in comprehensive cancer centers and will also share with us the experience that he had during this COVID crisis of the impact on his patients. The work that he's going to share has also been published in a Nature Medicine paper in April 2020 on behalf of all comprehensive cancer centers in a network of comprehensive cancer centers called the Cancer Core Europe. The second lecture will be given by Dr. Andreas Gutzeit, a radiologist from Lucerne. He has a specific relation with his radiological colleagues in Wuhan and was in very close contact with them at the beginning of the crisis. And recently, they published a paper in the European Radiology in May 2020 on the impact of workflows in radiological departments. So I would like now to ask them to introduce themselves more specifically, and I give the word to Dr. Sonke.
Thank you, Regina. My name is Gabe Sonke. I'm medical oncologist, head of the Department of Medical Oncology here at the Netherlands Cancer Institute in Amsterdam. I specialize in the treatment and also research of mostly female cancer, breast cancer, and ovarian cancer, but also involved in dealing with the corona crisis in our hospital and got the experience from a clinical and a patient point of view, and I'll hope to share some thoughts on that in the next talk.
Hello, everybody. My name is Andreas Gutzeit. I'm a radiologist from Lucerne in Switzerland. I'm specialized in cancer care. imaging, and we are working close together with the research colleagues from Wuhan in China. And what Regina told before, we published one publication about management during the pandemic and COVID crisis.
Thank you very much. As you've heard, all listeners, these are very excellent experts who can really share with us their own experience from the work floor. And I would now like to give Dr. Sonke the word so he can start his lecture. Thank you very much.
Thanks again, and thank you for inviting me to share our thoughts and some data on COVID-19 and cancer care. Next slide. I'd like to start with a patient story of a patient of mine, Lisa. She was a 66-year-old lady I'd known for many years with metastatic breast cancer. And her condition was quite reasonable, and she very much enjoyed life with her children and grandchildren. In March 2020, when we were all grabbed by fear of the emerging COVID pandemic, she canceled 2 consecutive hospital appointments with me. And I called her, and she told me that she'd been too afraid to come to the hospital, as her fear for cancer was actually overtaken by fear of corona. And therefore, she had spent her days at home in strict isolation and denied anyone to visit her for the past couple of weeks, including her children and her grandchildren. And actually, for cancer patients in the last part of their lives, there's of course a big impact on their quality of life. She also told me that she was deadly tired, felt nauseous, constipated, had severe back pain. She said, "Don't worry, I will manage." Obviously, I did worry and tried to persuade her to come to the hospital immediately, but I was unsuccessful as she was too afraid to get infected in our hospital. Well, luckily, she accepted her general practitioner to visit her, and he found her in bed with all signs and symptoms of severe hypocalcemic crisis caused by progressive bone metastasis, which were in need of urgent intervention. This is only one of several stories we have heard over the past couple of months. Our patients with cancer experience immense levels of anxiety caused by the fear of contracting the coronavirus on top of their existing malignancy. And many patients with cancer impose the highest degrees of self-isolation even before governments decided to go into lockdown. And many of my patients are still very reluctant to leave the isolation behind as they perceive themselves at very high risk of COVID-19. But we can question ourselves whether that is true. Are patients with cancer high-risk patients for corona? Maybe one slide back. So these are actually three main topics I'd like to touch upon in the presentation. So the question is, are patients with cancer at high risk? This is something that initial reports from China suggested. I'll show some very recent data on this topic from large prospective series in the UK and the US, which have been published in The Lancet recently. Our experience at the Netherlands Cancer Institute is actually that we see very few patients with COVID-19, and I'll share some suggestions on how we have dealt with the corona crisis and how we were able to minimize its impact on cancer care, and elaborate also on some of the good things that the crisis has taught us. Next slide. So our patients with cancer at higher risk. I think there are 2 series now that give us the best impact we have, although we must realize that these are still early days and we are learning every day, in fact. But the UK Corona Cancer Monitoring Project, they prospectively collected data on 800 patients with active cancer who were admitted to hospital for COVID-19. And about a quarter of these died during admission. But when they looked at which factors were prognostic for outcome, it showed actually the known factors for COVID outcomes, such as age, male sex, and comorbidities, were all related to poor outcome. But very interestingly, there was no interaction with anti-cancer treatments within 4 weeks. So patients who had active treatments recently did not have a worse outcome than those who did not have any chemotherapy, radiotherapy, etc. So this was one study from the UK, but there was another study published from the US, maybe the next slide, and was also presented at the recent ESCO meeting, in the virtual ESCO meeting. A very similar design, also a prospective series of over 900 patients, all with a current or a past history of cancer, and they were admitted to the hospital for COVID. And in this series, 13% of patients died within 30 days of admittance. And very similar to the UK experience, age, male sex, smoking, comorbidities were all related to poor outcome. But again, there was no interaction with anti-cancer treatment. Next slide. Now, these are the two largest centers, two largest studies on this topic. There are some smaller ones from Italy and also from China, but I think this is the best evidence we have. We must realize that there's only short follow-up. There's a lot of missing data. We only look at mortality, and there's a lot more to severe COVID than mortality. And we must realize that this is limited to hospitalized patients, where there's, of course, a large proportion of patients who do not get admitted to hospital for various reasons, either because they don't have severe symptoms or because they didn't want to come to the hospital anymore. But having said that, I think the next slide. The question, does cancer treatment increase the risk of severe COVID-19? I think the answer, as far as we now know, is probably not. It does not. There are other risk factors that increase your risk, but not so much cancer or its treatments. And are patients with cancer at increased risk of contracting the virus? Well, actually, that's something we don't really know. As said, these data were all based on hospitalized patients, and we don't know what the risk is for patients who stay at home. What we do know is that numbers appear to be low, but this can very well be due to the self-isolation that patients impose on themselves. But we know that cancer limits the immune system, and we know that a lot of our treatments limits the immune system. But as we heard about yesterday, maybe the next slide, maybe drugs that limit your immune system, such as dexamethasone, seem to be active against the severe sequelae of COVID. Maybe cancer and its treatments have a similar effect, and that may be one of the reasons why we see not that many severe outcomes of the virus in cancer patients. Next slide. So how does corona impact the cancer care? I'll share the experience of the Netherlands Cancer Institute in Amsterdam. So we are a comprehensive cancer center. We are fully dedicated to research and care of cancer, but it also means that we don't see any patients without cancer. We have close collaboration with academic and regional hospitals within the Netherlands. And during the pandemic, we were able to have very good appointments with the other hospitals in making ourselves a designated corona-free hospital, meaning that if there was a patient who needed care for COVID-19, we refer them to one of the neighboring hospitals for COVID care. And in return, we were able to take care of cancer treatment from the other hospitals. If they had limited capacity for cancer treatment, we could do that in return. And that worked out very well, meaning that the number of patients admitted with COVID in our hospital has been very, very limited. Nevertheless, we have a dedicated outpatient facility in which we triage and screen patients who might be infected, who have symptoms that may be related to corona, although many of the signs and symptoms related to cancer or its treatment may be very similar to the signs and symptoms of corona. So it's not very easy to distinguish both at the same time, at the beginning. We also do have a dedicated hospital ward. If there are patients who are suspected to be infected, they can be isolated in one specific hospital ward, and they can be triaged to other wards if they are free of corona, and they can be triaged to or referred to another hospital if they are infected. What we also do is we screen all patients before they come to the hospital. We have a dedicated telephone team who contact all patients if they come for a hospital visit, a treatment, a scan, or any other appointment. And we can have we have a lot of access to PCR testing, swabs, if indicated for testing on corona. And we also had rigorous testing of all personnel, making sure that the health workers were not exposed to our colleagues, to their colleagues, and making sure that there was not an outbreak in the hospital in that side. And we had access to personal protection equipment in high-risk procedures. Of course, I think many of us experience shortages of personal protection, but I think we've been able to also deal with that within the country and make good use of the available equipment overall. Next slide, please. Now, what we also did is make an evaluation of the necessity of, or priority of all patient activities in the hospital. And that was something that we also did in alignment with other cancer care centers in Europe, as Regina mentioned, but also within the Netherlands. So what treatments could be delayed or maybe stopped temporarily? Do all patients need to come to the hospital, or can we do video calls instead? Now that led to a large reduction in hospital visits. Waiting rooms were, well, not fully empty, but very few patients coming to the hospitals. We also stopped almost all clinical trials, at least temporarily, because we did not know what the impact of the trials would be on the patient, but also not what the corona would do for the trial validity. There were a few trials that were still open, for instance, studies that had limited or actually de-escalated treatments, such as we compare 3 chemotherapy cycles versus the regular 6 chemotherapy cycles. If the experimental treatment is less intensive, those were the trials that could continue. At this moment, almost all trials are back open again, actually. Just one back for a moment. Previous slide, please. We did not see a reduction in surgical oncology care. Some reconstructive treatments were postponed, but instead we had referrals for surgery from other hospitals. So our surgical, our ORs, or theaters were actually running full speed, and the same was for radiotherapy. But there was a 25% reduction in palliative, chemo, immuno, and targeted therapy use over the first weeks of the crisis. Next slide. Now, what I show here is data from the Netherlands Cancer Registry, which has a registry of all cancer diagnosis per week. And what you see here is that the number of diagnoses in the country was quite strongly decreased from starting March of this year. There was about a 20% decrease, or even further for some tumor types. And this is of course due, as you mentioned last week, due to the reduction in screening activities, but also to the reduction of patients contacting their doctors with complaints. And I'll get back to that a little later. Next slide. What you see here is the reduction in diagnosis since the beginning of this year for several tumor types, ranging from a 40% or a 60% reduction. No, that's a 40% reduction in skin cancer to about 20% reduction in bladder cancer, renal cancer. You see that this effect is true in all cancer types, not just the ones that we have screening programs for. Next slide, please. So if you do the numbers, you see that there are thousands of undiagnosed cancers still out there, and we must be prepared for a huge burden of new patients in the next coming weeks or months. We don't know whether this will be an immediate wave of patients or much more of a delayed wave of patients, but they will come to us. They can be separated in two groups. Those screen detected cancer, which will not be detected yet because the screening programs are delayed. In my opinion, this will not have too much impact on outcome if there's only a couple of months delay in the screening. Asymptomatic cancers, which are typically the lower grade cancers that you detect. But I think the largest impact is on patients who do not go to the doctor with symptoms and signs of their cancer. So the urgent need and message to all patients is to please go see your doctor. Don't be afraid of the corona cancer, because of the coronavirus, because a cancer is much more of a risk than the corona if you take all precautions. Next slide, please. Now, are there any good things in this crisis as well? Or as Winston Churchill said, never waste a good crisis. Never let a good crisis go to waste. Next slide, please. And I think there are. Having said that, there's quite a lot of treatments that we've delayed or postponed. I think that the current situation, and there's actually a statement from the Nature Medicine paper, which we refer to, the current situation offers a unique window of opportunity for assessing the effects of de-escalating anti-cancer regimens. But it also means that we have to take a good registry of everything that happens to our patients in the coming months. That's the only way we can realize or actually measure what the impact of all the de-escalation has been. But at the same time, I think we should also remember the ease at which we were able to downscale or de-escalate a lot of things we were so used to doing in medicine or in oncology. The ease at which we stopped palliative chemotherapy, I think we should realize that some of these treatments did not impact the patients at all, and maybe we should be realistic and make discussions with our patients also after the corona crisis that some of these treatments weren't necessary. We shouldn't have started them in the first place. Can we do with a little less administrative burden? My experience was also that some changes in the organization could be made over a day or overnight, whereas usually it takes weeks of a lot of discussions, and now we could make our decisions immediately, and I hope that we could take some of that along. And can we do with some fewer CT scans? We're used to making tumor evaluations every 6 to 8 weeks, but I don't think there was a lot of problems in doing that every 12 weeks or even every 4 months. So maybe we could do with a little less of that as well. And can we do with some fewer on-site symposia? There's been a virtual ESCO recently, and I think most of the information was still there. And also this ESR webinar, I think, is a very good example on how we can reach each other and talk to each other and share our information. So congratulations on this initiative as well. Next slide. And with that, I'd like to end this presentation on COVID-19 and cancer care, and I'll be very happy to take your questions.
Ups. Du kannst sonst noch mal schnell nicht mehr teilen. Regina, you're muted.
I'm sorry, that is that is the perfect example that it is live. So I was not heard. Anyway, thank you so much, Gabe. It was an excellent lecture. There will be questions later that we will address, but I already have burning questions. In fact, what is so interesting you shared with us is that there were, of course, fewer CT scans. We learned from this period that perhaps we can prolong the period between the follow-up scans. But also you mentioned that maybe even you can question the role of palliative chemotherapy. Well, from a medical point of view, I can understand, but what was when everything is now starting to go to the new normal, what is it that your patients, how does your patients address this? Did they suffer? Do they still ask you? Did they feel that they are undertreated, or that you even don't care so much anymore? So what were the reactions of your patients?
Well, great question, and I think there's a lot of patients, there's a lot of people and a lot of experiences. Some patients still don't want to come to the hospital, and they are so happy they don't want to come, that they don't have to come, and that's much more important than continuing their treatment. Whereas others, if we decided that some treatments had to be postponed, they just could not accept that, and they were willing to come no matter what and continue their treatments. So each situation is different, and of course the situation in palliative care is completely different if you're in first-line breast cancer or melanoma compared to last-line pancreatic cancer. So you have to take all these things into account. And when I mentioned that we could do with a little less chemotherapy, I was specifically mentioning on last lines chemotherapy, which have a very low response rate and very limited impact on progression-free or even overall survival. But very many different opinions from patients, and I think it was very important, and it took a lot of and still takes a lot of video calls and telephone calls and discussion with patients to see how everybody feels about it. So that's really shared decision making as well.
Yes, yes, I can imagine this is a new world of sharing information with patients, and it must be very hard also for you that you sometimes have to do it at a remote in a video conference. So I can
For
imagine
sure.
there are, yeah.
Yes,
so
for sure. I think it's something we have to get used to as well. I mean, bringing bad news to patients over a video conference or even over a telephone line is really so much difficult and so much different than what we're used to. And if you realize that over 50% of our communication is non-verbal, you realize what we are missing and how difficult it can be to have a good conversation, something that we have to learn ourselves as well.
Yes, I can imagine that. That's very interesting. So we will pick up more questions later, but now I would like to give the word to Andreas to share with us his experience from the Wuhan departments of radiology.
Yeah, dear ladies and gentlemen, dear friends of the ESR, have you ever thought about how well you're doing? I don't mean that you are sitting safe and probably healthy in front of the computer right now. Imagine the history of the human mankind in the last 200 years. For example, poverty has been reduced across the continent in recent years as never before in the human history. Infant mortality is as low as has ever been before in human history. Never before have so many people worldwide been vaccinated. This is a great achievement of mankind. We are really the glory of creation. We are Homo sapiens, where sapiens means wise. But we have not always been alone. Until 30,000 years ago, there were numerous other apes living together with Homo sapiens, such as Homo neanderthalis. They were stronger than us. They had more hair than us. They were better prepared for the cold. But they did have one small disadvantage over us. No living creature can communicate and coordinate in such a complex way as we, as Homo sapiens. This enabled us to hunt better, and by the way, we are able to displace the Neanderthal and the many enemies. That means the key of our success is communication. Communication is the success of everything. So when people stop talking, that's usually not a good sign. I will show you a moment when I, and probably most of you probably did not have the words to describe something. It was the 9/11 attacks in New York. Most of you know the historical situation when George Bush was informed by the chief of the staff in that moment with the words, "Mr. President, America is under attack right in this moment." Mr. Bush then sat in front of the school class for 7 minutes and said nothing. He looked blank. Many commentators later interpreted this as a stupidity. Even if I disagree with him as a politician in the subsequent wars in Iraq and Afghanistan, that a person is silent in that moment is understandable and a part of human. So that shows that we can move in the world with communication. With agreements and communication, we have managed to deal with so many dangers as humanity, and we will continue to do it in the future. But on 9/11, there were also a quite success, and people showed that they were capable with good communication. My brother gave me this picture. He's an airline pilot by the Lufthansa in Germany and worked as in the airspace on that day. There has never been anything like this before on 9/11. When the terrorist attacks took place, all of the planes were forced to land within minutes. I can tell you, my brother is completely different to me. He plans everything. When we meet, he first looks at where the emergency exits are in the cafe and then takes me in his arms. What I want to say, pilots are preparing for everything, but something happened on that day and that nobody had ever experienced with like this. Look at how the air traffic was at 9/11. When the terrorist attacks begin, and to see how quickly the planes land. This were unplanned landings. How could that work? Large parts of the telephone network in the US collapsed on that day. Some of the employees in the towers called friends and owners of small airports, and there were private mobile phones. They asked, if I have an airplane here in my airspace, can you help me to land there? There was a great trust between the employees of the tower, the airports, and the pilots. Otherwise, it would never be happened. The American aviation authorities later wanted to put this process into a standard procedure, an SOP. They said afterward that cannot be defined. That is a human communication. The most important thing is trust, communication, and relationship. These are the three things to manage every disaster in the humanity. What can we doctors and scientists learn from this? And can it help us organize a pandemic? I guess so, yes. I don't treat a pandemic to anyone, but when is the best time to a pandemic? I think today. I have a good friend in Wuhan, Liang Wang, in China, in Wuhan. When the pandemic in Wuhan rose sharply with COVID-19, I knew this personally from the personal story of my colleague. Liang gave us all the plans and the disaster authorities from Wuhan and how they managed the disaster in December and January this year. And from my assessment, Wuhan handled it very quickly and sufficient. You don't have to write letters today or go by a plan. You can share documents and experience online in seconds. Colleagues like Liang from Wuhan and other colleagues from Asia gave us all the data in a positive way how to manage the threat here in Europe. We tried to publish this data in February. Unfortunately, that didn't really intersect the big journals here in Europe and in US in February. Fortunately, the publication worked in European Radiology in March. I want to say that the pandemic should always be organized under the umbrella like the World Health Organization in accordance with international coordination. I think pandemic should be organized with a scientific focus and work together as humanity and not in countries, and trust, relationship, and communication is a good way to deal all these problems. What could we learn from disaster 2003? Disaster epidemic is not comparable to scale to COVID-19, but the comparison is still important. Sure, with about 8,000 cases, the extent is much smaller than COVID-19. But look on the most infections in Singapore. About 40% of patients probably got infected during their work. Asia had similar cases in the SARS pandemic as the West this year with COVID-19. So it's surprising that the West underestimated this, and protection material was very scarce in the early days of the pandemic here in Europe and the US. I think this is very important for future disaster control. Sufficient protective material and sufficient reserve of disinfection material is very important, and we have to manage it in the future better. In the event of a pandemic, trade and commodity chains collapse. For this reason, it will be necessary to consider how such products can be produced quickly on site here in Europe or in the US, above all independently. What can we radiologists learn from Wuhan? It is quick to set up emergency hospitals like here in Wuhan or in Nottwil in Switzerland. I think that this hospital construction in China was very skillfully accompanied by the media. I think that Europe and the US quickly built their own capacities. Now, in my way, there are two important things what we can learn from Europe to Asia. First, in March 2020, Wuhan radiologists had exactly 3 months more experience than European radiologists. And second, Asia has simply had more experience in such disaster than in the West since the last 16 years. An important question is, when did the disaster training start within hospitals in Wuhan? The question is answered from the provision slides, but the great experience in Wuhan is really, really interesting. They start with a training immediately after beginning of the pandemic, and they trained the medical staff, the administrative staff, and the service department, including the security and all the other things. The training content was standard prevention, personal protection, hand hygiene, and all these things. In particular, e-learning was an important part. We also did it in our hospital, and we were very surprised how sustainable and efficient it worked in such a catastrophic situation. What were the management process in radiology departments during the crisis? I think there are two important things. Maintaining, first, is maintaining the service to all patients, because the speaker before told the same. The world doesn't just resolve around COVID-19 anymore. There are oncology patients, trauma patients, and all the other things which is normally in hospital. And the second is we have to avoid cross-infections between the medical staff and the patients and the medical staff. So let's come to avoid the cross-infections in the hospital. In Wuhan, in our hospital too, we learned from Wuhan, the workplace were clearly divided into two different zones, with a COVID zone and a COVID-free zone. And there was standardized cleaning procedures, which is right down in the paper. And the removal of protective clothing and disinfection is also very important. Despite possible impairment of scan image quality, we always use protection material, such as masks during the examination. I think patient crossing was reduced in the hospital is very, very important to prevent this cross-infection. So the 2 meters between the patients and to protect our own staff is a very important thing in such a situation. The work in areas without confirmed COVID-19 patients. In this case, it is important to realize that self-protection is extremely important for our personal and operational safety, but above all for protection. There seems to be no material shortage in Wuhan. The colleagues had full protection in the infectious zone all the time. That also applies to radiology. In the zone not affected by COVID, in Wuhan was used every person FFP2 mask and disposable protective material available all the time. I think this point is very important to me. Our staff is extremely motivated. The fact that there was major bottlenecks in Europe and the US, at least at the beginning of the crisis, was not easy to communicate with our staff. In the beginning, we saw many people who tried to protect themselves with their own inventions was very creative, but this is not normal. We expect Europe and the West to better prepare for the next pandemic, but sure is to come. So disinfection of computers, keyboards, and other equipment is very important to avoid cross-infections. After each patient, the radiology rooms and keyboards of the computers were cleaned and according as a standard. I do not want to bore you with the details, but you can see everything in the paper, which is described very in detail there. So as I mentioned earlier, nobody wants this pandemic. But compared to the history of mankind, we have incredible possibilities of fast communication, internet, and above all, the chance to learn from each other and make communication together and deal this pandemic in the future. If you look at the fact that these things are disregarded at the political level, the collaboration with the World Health Organization is broken off, and much more that personally makes me sad, sometimes remind me of our hospital procedures where experts and patients care are not always sure. Sometimes the whole things remind me of this scene. Look what happened when you don't work together, don't look at each other, and don't communicate. It works somehow, but at the end of the patient's benefits the least. I think we have to learn from this. This is not good in management for dealing a COVID-19 crisis. So we have to work together with all disciplines in all over the world. That's how I imagine cooperation. See how we are trying to remove a magnetic chair from the MR scanner cleaning accidentally sank. Take a look at how our team works. Clear processes, everyone is looking at the same direction, everybody communicate each other. This is how we should manage a pandemic. Trust relation communication is in the pandemic very important, but also in normal processes in hospitals. In the end, I would like to thank the people who are part of our research teams and who were involved in the COVID study. A big thank you goes to Liang Wang and the Radiology team from Wuhan, and who always forward us for information unfiltered. Thank you, dear Lang colleagues from the Wuhan. In the end, I would like to end with the last sentence of our publication. This part is particularly important to me in times when governments are resigning from international health authorities for political or electoral reasons. There's one positive thing about the COVID-19 outbreak. It is the insight that humanity can only solve today's complex problems through international collaboration. Scientists are particularly important participants of such discussions as they find solutions collaboratively based on scientific evidence and rational thinking. So many thanks. If you have any questions, I would like to give you my contact address here with this email address. Thank you very much for your kind attention.
Regina, you're muted.
So I'm so sorry I did it twice. I shouldn't do it anymore. Thank you very much, Andreas. That it was an excellent presentation. Also, the Wuhan experience was, of course, something that we can learn from. So thank you very much also to our Wuhan colleagues for sharing this with us. Meanwhile, the chat questions are coming in. Before I address them, Andreas, I would like to
Sorry, Regina, we can't hear you again.
Oh, okay. So something went wrong with my microphone. Hope it will not automatically put on mute again. I'm so sorry about that. Apologies. I will repeat my question to Andreas. What is Wuhan's experience, or maybe your own experience, of how the personnel on radiology departments or on hospital wards or operating theaters mentally dealt with the crisis? I mean, when it started, we were overwhelmed and maybe had our own anxiety. Do you know, was there a specific experience that we did not address so well and where we can learn from?
This is a very interesting question, not easy. I discussed it with Liang. I think the Chinese management is completely different to European management. I asked at the beginning, my friend, how you deal with all this pressure in Wuhan. It was an incredible situation. And he said, that was no problem. We have a plan and we have to work with it. I think this is completely different to Europe. In our hospitals, especially in the beginning of this crisis, our staff sometimes was a little bit fearful and scary about the situation, but it is not comparable to the situation in Wuhan. I think they have experience, especially with SARS, and they was very well prepared. I think the difference between Europe and Asia was that Europe and US was not very well prepared for this situation, but Asia and China and Wuhan was very well prepared. So that was the reason why Wuhan colleagues was working with a clear plan.
Yeah. And would you think we have learned and we would be better prepared now, also not only based on the experiences of our colleague in China, but also on our own experience? You think that Europe is more prepared now, know what is what are the issues that we should address better after this, in the aftermath of this pandemic?
Yes, I think so. I think the situation is going on right now, but this crisis will be gone. And after that, everybody will ask by himself what was in the past 3 months. And I think in the future we are better prepared. I'm absolutely sure about that. Governments are better prepared, doctors are better prepared, and hospitals also will be better prepared in the future. I'm absolutely sure about that.
That's good to hear. One of the questions from our participants is for Dr. Sonke. There is a compliment to you. Great talk, Dr. Sonke. The question is, how will you evaluate the necessity of the follow-up scans? So you mentioned briefly about whether there is a question raising this during this pandemic. Okay, instead of 6 weeks, maybe each 12 weeks, that would not compromise. What do you think? How shall we, radiologists, or maybe the entire multidisciplinary team, evaluate this?
Yeah, thanks. A very good question. I think it is important that we at least learn from the experiment that we've all done together the last couple of months. And there's a lot of registries going on in the various countries on following our patients. How do they do compared to before or after the corona crisis. And just learning about from that, seeing that we did less scans, that we did give less chemotherapy, how much did that will that impact on the real outcome, on quality of life, what is measured, and on progression, but also on survival. If we really want to go for a higher level of evidence, I think we need to use that information from the past couple of months and turn that into new protocols, or even to studies in which we de-escalate our treatments and we de-escalate our evaluation schedules.
Thank you. That is a clear answer. There is another question from the Philippines. Thank you, doctor, in the Philippines, because I think it's very late in your country at the moment. How do you handle, Dr. Sonke, the screening of patients to be scheduled for a radiological exam? Do you think they still need a swab test before the exams? It's just... it's in fact a question that could also be addressed by radiologists, but I'm curious about your view.
So what we do is all patients that have an appointment for a scan or any other examination, they are called by our telephone team one day before to see if they have signs or symptoms, or relatives that have signs or symptoms that may be related to corona or to COVID-19. If so, then there was a contact with the doctor who asked for the scan, and to see whether it's really necessary for the scan to continue. If not, the scan is postponed until the complaints are postponed. In that sense, we don't need a test. If the scan cannot be postponed, patients come to the hospital and need to be scanned or need to be tested. So therefore, I think the triage is very important. The pre-screening is very important to limit patients with signs and symptoms in the hospital only for those that are really necessary. And if so, we test them before. And if they have to come to the hospital, we have all protection measures in place as well.
That's a lot of work, workload also. Did you hire specific personnel to do this during the crisis?
Yes, we did. Well, in the beginning, we had to work with everybody who's just working in the hospital. So a lot of people doing other things that they were used to at the beginning. There was a lot of rescheduling. Nowadays, I think things have gone back to a new normal. Indeed, we are hiring new personnel to do so, and these can be new nurses to do testing, or we have students in place who do the telephone calls. So yes, there is a lot of new personnel.
Okay, interesting to hear. For Andreas, there is a question, Andreas. How was cancer care affected in Switzerland and by COVID? Did you split also into COVID and non-COVID hospitals like we heard that was done in the Netherlands?
No, this is a good question. We don't split hospitals. There are different experiences. In our hospital, I have a statistics. We have a reduction of oncological imaging roundabouts of 60%. So this is a reduction of 60%. But the oncological clinic works the whole time. So every patient become an oncologist when it's necessary. But I also heard from other hospitals, especially the bigger hospitals in the other parts of Switzerland, and they reduced in the first time of the crisis the oncological patients round about 70 to 80%. So this was a very significant reduction. In our hospital, we had a reduction around about 60%. I think the situation is still going on. We have to analyze it at the end of this crisis, but in Switzerland it's completely different because this country is had different governments inside the country, so it's very difficult to compare our hospital with with other hospitals.
Yeah. Okay. Clear. And another question I have is, Dr. Sonke, you mentioned that there was a drop in the people who went to the general practitioner with complaints. So what do you think? How can we deal with this late diagnosis? Because I assume that they did not go there because they were a little bit afraid, right? So I can imagine that tumors are diagnosed in a more advanced stage. Um, how can we keep up with this? How can we, make these our nation aware of the fact that they should go to their caretaker, and maybe what kind of means could we do and use the television, the media, or maybe webinars? What do you think? How can we cope with this and
Yes,
address
I
this?
think this is one of the most important say consequences of the coronavirus on other diseases, and it's not just cancer. I think cardiovascular diseases is equally important, and there are various others as well. Delayed diagnosis of urgent diseases is really a big issue, and I think the general practitioners themselves need to be really outgoing in telling and making sure their practices are safe, and making sure the patients come. I also think that it's something that the hospital should actively communicate outside, and whether it's done in newspapers or television, I think it's important that the message is spread over and over again. And I know in the Netherlands, the Organization of Medical Specialists is one of the organizations that actively spreads the word and makes sure people please visit your doctor if you have symptoms, and that needs to be said over and over again, because still the number of diagnoses is below what is normal for the period of the year. And that leads to late diagnosis, that leads to worse outcome, but also leads to a peak in treatments that are necessary in the rest of the year. And we must be able to cope with that as well, and prepare the hospitals for the lots of patients that will come.
Do you think that we are prepared for this period of the aftermath of the crisis? Are we prepared enough? Is there a protocol in place to handle with this, or do we still need to improve and work on it?
My experience is that we now deal a lot about how to deal with a next wave of corona. So what do we do if there is a next episode, if there is a new increase in patients? We're very well prepared for that, but I'm not so sure whether we are prepared to deal with all the diagnoses that will come, and whether we'll have enough capacity to treat those late diagnoses. And I think it's really important for all hospitals and countries to take care for that as well, and not just make sure you're prepared for corona.
Yeah, that's very important to take. I have a question for Dr. Goodside from the chat. Are there any data from China on COVID impact on cancer diagnosis, since they were some weeks ahead of us?
Unfortunately, I have no data. I talked with Liang, and they was extremely focused on management of this crisis, but I have no data from Wuhan. But what is also important, especially from Gabe, what Gabe told before, in our hospital, it was very impressive, the collateral damage after the beginning of the COVID crisis, around about 2 or 3 weeks after that. There was a lot of people with huge problems, especially in the abdomen, with appendicitis or cholecystitis or other things. I think this is a very important thing for the future, to manage all these collateral damage, because it doesn't make sense when we save people from COVID, but at the end we have more patients died with simple diseases. So that's a very important thing to discuss it after the crisis.
Okay. Now a question that can be taken by two of you. What did we bring from this crisis? I mean, as I told you, there's already this webinar kind of teaching. We all take part in Zoom meetings. Well, it saves us travels to congresses, because you learn a lot via your screen, although I have to admit that it's not exactly the same because I miss the social contact. But what do you think? Will we take some of this digital kind of methods, and which one do you think will sustain? Maybe first, Gabe?
Yeah, well, if from a clinician point of view, I must say that a lot of patients very much appreciate the ability to have video contacts together with face-to-face contact. So normally we see patients coming to the hospital a lot of times, but I think you can really reduce on that, and that has an advantage for patients as well to have their consultation from their own rooms. I think that is one easy thing. The level at which we are able to have video consulting is so much better within a couple of weeks. Normally it would be taken at least a year to have systems that we have in place right now. So yes, I think that is something that that patients will appreciate for sure.
Okay, that's interesting. Andreas, what do you think? Do we radiologists, we have a different look at the digital side of our specialty? Of course, it's all digital, but this is another way. Do you think we will work in a different way?
I think this is an important and very interesting question. I think what is important after this crisis that we think about the work of our healthcare system. When we think about 1 year before, by the ECR, everybody is talking about artificial intelligence and searching nodules in the lung and all these things. It sounds beautiful, but in this crisis, all these techniques doesn't help. In this crisis, it was important that we have a internet connection which works. So I think this is a very important thing to think about what is our infrastructure and where are problems to improve the infrastructure. And after that, we can discuss all the things, artificial intelligence and reducing doctors with computers and so on. So let's talk about the real worth of healthcare systems in the future.
That's very wise, and that's very important that we should first get the basis right. That's in fact what you're saying. Well,
I think maybe.
Very, yeah. Yes.
I think
yes.
one other thing to mention, and we should take from this, is the level at which we were collaborating, and each healthcare professional was so dedicated to delivering the best care possible, and step beyond each borders to collaborate and deal with this. And I think especially all the nurses in the wards and all the doctors at the ICUs, it's such a tremendous job, and I think that's something to take into as well and keep there.
Did you have yeah, sorry, Andreas.
This is also my point. This is the kind of worth of healthcare systems that are all there. We are not always doctors in hospitals. There are nurses and other persons in the hospital, and they make a tremendous job in every day. And we don't forget this person and to think about the worth of all these people in our hospitals.
Interesting. I wish we could continue more, but I'm looking at the time as well. There is another question that is for Gabe, I think. Do you have any apps for the follow-up of your cancer patients? Do you have them? Do you use them? Or is something being planned?
There's actually a lot of apps already developed and further developed for follow-up of patients, also for them to communicate with their doctors, to give their signs and symptoms, and they can also be used in algorithms to see maybe the need for follow-up visits. In our hospital, we're experimenting with that. It's not something that we have in regular practice, but we have a lot of contacts with app developers, and I think that is something that we will use in the future increasingly.
Okay, interesting. Okay, I think that we are coming to the end of our session, which is very interesting. There is one last personal question. You can say from your personal point of view and not from your professional point of view. If, I hope we will not, but if we face again another pandemic overwhelming peak, what would you do different with your knowledge now? Andreas or Gabe, you can start. I ask it to both of you.
I have an idea. I would absolutely reduce television and all these things and always use scientific papers. That is a better way to keep the mind cool and to find good solutions. No television and no media, especially this special kind of media which describe all the situation very dramatic, and that doesn't help in this situation to be cool.
That is very good. That's very good advice, learning point. Gabe, what is your?
I think, and that's somewhat related to what Andreas is saying. I was impressed with the level of anxiety in healthcare workers as well. It's not just the patients who got very scared, but it were the doctors as well and the nurses. Everybody was very scared, and I think we did not pay sufficient attention to that at the beginning of the crisis. Maybe that's something that the Asian were more used to, and I think that's something very important to do from the very start if there would be a new crisis, to pay attention to all the professionals as well and their fears.
Thank you. Well, I think I have learned a lot. It's bad to say that such a crisis gets you to this point that you can tell that we learned a lot. But at least we know that for cancer patients, the message is that please go to your doctor. We all are here to take care of you, and it is important that you do not wait too long and with your symptoms. And for radiological department, we learned a lot from you, Andreas, and from the Chinese colleagues, how they manage this crisis incredibly phenomenal way. So this session was very interesting, I'm sure also for you attendees, but that is because of your excellent input. So my big thanks to Dr. Sonke and Dr. Goodside for taking part in this and sharing us your experience and information. Thank you.